I would like to welcome you to this first session of the 2022 University of the West Indies School of Clinical Medicine and Research Day. I have the privilege of serving as your moderator for this afternoon's session. My name is Dr. Philip Swan. This afternoon's session reads as one of excitement and broad scope of topics. It is also packed, and we hope should not have you in session too late this afternoon. We do have some rearrangements to make due to prior commitments of one or two of our presenters, and we therefore seek your indulgence as we move items around on the agenda. So without further ado, let's start with prayer and then dive right into our presentations. Invite Dr. Mortimer Moxie to provide prayer for us for today.
Good afternoon, all. Our Father God, we thank you for this day and this wonderful opportunity for us to meet as physicians and allied health personnel to do your work in the area of research. We adore you, we worship you, we confess our sins, and we thank you for all that you have given to us. We ask your blessings, your guidance on these proceedings. Give the speakers clear thoughts and excellent delivery. We thank you for the planners who put so much into this and our research participants who gave of their time to engage in research with us. And at the end of all of this, we ask you to allow us as physicians and health professionals to apply this wonderful knowledge that will be imparted during this event as we seek to help, to promote health, to improve health, both here in our country, in the Caribbean, and indeed globally. We ask all these things in Jesus' name, amen.
Amen. Thank you, Dr. Moxie, for those
You're welcome.
words of encouragement. So our first speaker for today will be Dr. Lisa Indar. Dr. Indar is the director of the Surveillance Diseases Prevention and Control Division at the Caribbean Public Health Agency, or CARPHA. She is described as an innovative public health scientist specializing in infectious diseases, travelers' health, and food safety. Dr. Indar has 18 years of regional and international experience in managing and executing regional public health surveillance and response programs. She has demonstrated robust leadership, multidisciplinary technical expertise in the areas of epidemiology, microbiology, food safety, and environmental health. And she has expertise in health diplomacy, communications, implementation, capacity building, and resource mobilization. Dr. Indar is the holder of a PhD with high commendation, a MSc with distinction, and a BSc with honors. Her current responsibilities as Director of Surveillance Diseases Prevention and Control Division includes directing, coordinating, and managing public health surveillance and response activities related to conditions of regional and international importance. She is currently the technical lead for CARPHA's comprehensive, multifaceted regional health response to the COVID-19 pandemic, working with CARICOM heads of states, heads of governments, public health agencies, and international, regional, and national multi-sectoral stakeholders to keep the Caribbean safe while promoting a safe economic recovery. Dr. Indar also leads the Regional Tourism and Health Program, THP, that works with CARICOM member states to address the health, safety, and environmental sanitation threats to tourism. The aim of the THP is to strengthen regional and national health systems in a bid to safeguard and enhance the health of tourists, of visitors, and locals, and thereby promote sustainable tourism and economic resilience. For the record, CARPHA is the premier and only public health agency in the Caribbean that is responsible for preventing disease, promoting and protecting health in the Caribbean, and it currently serves 23 Caribbean countries. As our keynote speaker for today, Dr. Indar will speak to us on the topic, the impact of COVID-19 in the region. Colleagues, I invite you to turn your attention to Dr. Lisa Indar. Dr. Indar.
Yes. A pleasant good morning. Thank you very much on behalf of Dr. Joyce and John. CAFA thanks you for inviting us to be part of this very important webinar today on the 15th research symposium on resilience in healthcare delivery. So my presentation would deal with COVID-19, its impact. And because it's a research, it's dealing with research, I wanted to talk about what we are doing in terms of recovery. So if you permit me to share my screen. And I want to thank the chair for giving us the opportunity to present first, because we do have another conference that starts at 2 p.m. So this is the name of my presentation, The Change in Dynamic of COVID-19 in the Caribbean and CAFA's Response to COVID-19 and Other Public Health Emergencies. So I wanted to start with this, to say that, pandemics and public health emergencies are not new. So if you look here, and because you like to do research, from since 1966 to now, we have been seeing a different set of public health emergencies. But the thing is, COVID-19 pandemic is not over. And even though the world thinks it's over, the WHO has not declared this pandemic to be over. But while all that is happening, we are seeing that monkeypox was declared a public health emergency in 2022. We're seeing a resurgence of polio and influenza and other diseases that are increases. So really the Caribbean is facing this myriad of public health threats, infectious diseases, natural disasters, man-made events. And all of that is really amplified by the fact that our borders are quite close. So what is happening in Trinidad is going to impact what's happening in Bahamas and vice versa. And what's happening in the US is going to impact on what's happening in our neighboring countries like the Bahamas and the Turks and Caicos and so on. What's happening in Haiti right now with cholera is going to impact on the rest of our countries because our borders are close. And they're not just close, but they're very porous. And also because we are tourism dependent. So it means travel and trade is big and is very frequent. And in fact, we are the most tourism dependent region when you think about travel. So all of this really increases our vulnerability for new and emerging infectious diseases like COVID-19. And it impacts on the region's capacity to prepare for, as well as to respond to public health threats that transcends national boundaries. So this is the type of this complex mosaic of public health threats that are impacting the Caribbean, and it is wide ranging. It's vaccine preventable, vulnerability to disasters, vector-borne, food and waterborne travelers, respiratory, and so on, STDs. And in the past 5 years, we have seen new threats like chickpea and Zika and so on. And we are now also seeing recurring threats, malaria, yellow fever, measles, polio, and norovirus. And why is all that so important? Because the Caribbean is unique. First, we are small. We are diverse. We have varying cultures. We have varying levels of development, surveillance, and laboratory capacities. We are close. We are interconnected. Our borders are porous. And we have, because of where we're situated and because of our size too, we are vulnerable, very much vulnerable to disasters and climate change. And we have a high dependence on tourism, and we are facing this complex myriad of public health threats. So the regional health security, our ability and our health systems ability to respond to public health threat is now more than ever must be concrete and must be able to withstand these myriad of public health threats. But it also has to be flexible and innovative enough to build and strengthen the region as we continue to face COVID-19, monkeypox, and other new and emergent threats. So how do we do that at the regional level? So when it comes to a regional emergency, there are two types here. It's a public health emergency or a disaster like a volcano or flooding and so on. If it's a public health emergency, CAFA will tend to lead in its response because that's our mandate and our IGA from our member states. And we would then convene, we have something called a regional health mechanism for health security. So we will convene that, or we will convene our own IMT-ER, which is our incident management team, and we will work towards responding. This is CAFA's a major role of CAFA, to be there to help countries to respond to public health threats and to build capacity as such to do the same. If it's a flood or a disaster, our partner agency, the SCMR, will lead a response, and CAFA will support through the regional response mechanism, where we would provide surveillance, environmental, shelter, wash assessments, and so on. And I'm sure you know about some recent emergency response that are listed here. How do we continue and prepare? How do we prepare and how do we continue to respond to public health threats? We do so through a holistic, multifaceted strategy for responding to public health emergencies, because we know one sector can't do all. We know it's not just a health sector response. We know we have to have a framework. We need to have coordinations among the different sectors. So we coordinate at the highest level with our ministers and our heads of government, and then we work with our chief medical officers, our partners. We have the regional coordinating mechanism for health security, and we work in a cohesive, multi-sectoral fashion to respond to public health emergencies. So let's go on to COVID-19. So now, you know, it's past 2 years that COVID started, and it's still a pandemic. And this is the global figures as of Monday. We have over 621 million confirmed cases, over 6 million deaths. And in our countries, the Caribbean, we have had 4.2 million cases, 35,000 deaths. And in the CAFA member states, we have had 1 million cases, around 1 million plus cases and 15,000 deaths. When you look at the persons vaccinated, though, our number of vaccination still is low. So 31 months and counting, and the COVID-19 pandemic continues. What have we learned from this pandemic? How have we responded? What have we been too distracted to see? And how do we move forward? Those are the questions we should ask ourselves. This has been our response to COVID. We tried to put it in one. You know, we have led the public health response from regional coordination, laboratory support, you know, from initial testing to now gene sequencing. We are tourism dependent. We know that is important, and that's super important for Bahamas, as Bahamas is highly tourism dependent. So we have created a tourism task force where we work with the Caribbean Tourism Organization and the Hotel and Tourism Association and the Global Tourism Resilience Center. So we ensure the harmonized messages are being sent out. We have supported vaccination. When we started to do epidemiological surveillance, we used to have 3 situation reports per week. We are down to 1 per week, but we do an epidemiological surveillance. We also send out watching briefs. We work with our sectors. We work with health and tourism and security and education. We have supported over 60 technical guidelines and to promote health in the tourism sector, because we want to promote safe travel, because we all know travel contributed to the spread of COVID. So to promote that, we offer a healthier, safer tourism stamp. But to get the stamp, you have to go through a process of training, and you also have to be reporting that illness. So we think it's very important, because if they do these proactive health measures, we know that we'll have a healthier, safer local as well as our visitor population. We do a lot of capacity building, risk communication, and we support in terms of risk mobilization. So this speaks up about different tools, surveillance, knowledge, capacity building, research, and we have done a lot of promotion and advocacy. And, we would have done upwards now of 252 situation reports. We still have 65, we have 66 technical guidelines, and we have 85 vaccine updates and a lot of dashboards. I encourage you to go onto our website, and all that we do is on our website. The way how we have been able to fight and to mitigate against COVID-19 has been through regional coordination. So if you look at the graphs, you would see in the US and the UK and Canada, you had big spikes. But in the Caribbean, the spike was not as large or as high as others. And that's because we had regional coordination from the beginning. So the regional solidarity from our heads of government, which CAFA worked with, we agreed from earlier clock in June 2020 to lockdown. There were some countries that didn't have cases as yet, but we locked down so that we will protect our economies, to protect our countries and the region. We then developed a common health policy. We had intra-regional travel protocols. We worked for joint procurement of medication and supplies and equipment, food security, and we had coordination with our other CARICOM partners to ensure that the measures were not suppressed. We had many different coordinating mechanisms. At CAFA, we work internally with our incident management team for emergency and response. We've participated and we lend technical advice to our heads of government meetings. We speak to our CMOs daily and many times a day because we work with them, WhatsApp chat, and they guide us and they tell us what they need and we work with them to do that. And then regionally, we work with our partners, SCMR and PAHO and UWI and others, where we have a core coordination group to talk about what everyone is doing and how do we coordinate better. We have also have an expert advisory group, a security cluster like impacts and so on, because, you know, mitigating this went across the border. We have the regional coordinating mechanisms, links to countries, and a lot of group planning. And at the global level, we will working at high level with our partners. We have partnerships with every major health agency. And we have also partnerships. We are part of the whole Access to COVID-19 Tools Accelerator Facilities Council meeting. And we were chair of the Action Package, the Global Health Security Action Package for AP3. It was a complex, and it is still a complex situation. So what it involves, and this is a lesson as part of the research we're doing, it involves multiple coordination and layers of coordination with multiple sectors. It was not just health. And this is a lesson for all of us to learn. Anytime we have a situation, because we are so tourism dependent, because our borders are porous, because of our varying capacity, we need to coordinate with all our sectors if we want to mitigate prevention and response. So here you see tourism, academia, security cluster, business, education, maintaining governance, and working at the core with our ministers of health and CMOs. And at the highest level too, we had the CARICOM Secretariat working with us for coordination and for policies measures. And of course, we had specific measures for our tourism and health through our tourism and health program, because again, visitors were coming in. Our first case of many illnesses we see through our visitors. And we did not want to curb our visitors because that's our bread and butter. But we wanted to ensure healthier, safer tourism. So to do that, we created a lot of guidelines. We expanded our early warning and response systems for all the accommodation setting, as well as the cruise ship setting. And we gave the stamp, and we produced a suite of travel measures so that, you know, we can encourage persons to do the right thing. And through the COVID Tourism Task Force, we are trying to send out harmonized messages. So what have we learned? Some 10 lessons we have learned from these 2.5 years of COVID so far. One is infectious disease is a whole of society approach. We cannot do it with health alone. At this time when this publication was published, it said 1 in every 1,300 persons alive in 2019 had died from SARS-CoV. We need that whole society approach. Because even though we were doing everything at the highest level, it really came down to the man on the street having that responsibility to say, I'm going to wear my mask, I'm going to social distance, I'm going to wash my hands. It came down to that. The other thing we noticed, the vaccine development paradigm had been transformed for emergencies, potentially for more, but we see inequality in that. By the time the Caribbean got vaccines, you know, many of the developed countries got before us, and we saw deaths and we saw spikes. There was So therefore, conversely, the weaknesses in vaccine manufacturing and equitable distribution really requires change. And we need to have that. We need to have equitable distribution, not just in vaccines, but for procurement of supplies. Because in the beginning, we could not get supplies for PCR and so on. The other thing we learned is trust is one of the most delicate but critical requirements for effective pandemic response. Trust across the borders, the health sector, the tourism, the finance, the security, and so on. You needed that trust. Another was agility and speed will be the new basis for differentiation. We can't wait. We must always be prepared. We saw that there was a lot of gaps in our surveillance system, and we were still, when COVID came, we were caught in sometimes with our pants down in the sense that we were now looking to strengthen surveillance and laboratory and logistics. These are things we have to keep working at because, a next pandemic will come. We can't say it would not come. The trend shows it will come. Government policies matters, yes, at the highest level, but individual behavior matters more, and we have to tailor our responses, our advocacy messages to really give our individuals, to instill in them a sense of responsibility to do the right thing. Schools are the true fulcrum of the function of the society, and we saw during the COVID lockdown how education was effective. Work, therefore, will never be the same. The economic stimulus works, but only in concept with strong public health measures. And whether we experience these problems again will depend on us. How do we now invest for pandemics? How do we strengthen our health systems? How do we strengthen that whole coordination across all the different sectors to ensure when something comes, we are better equipped? Some of the things to consider: the digital and the virtual work. We saw that work for COVID. Can we extend that? Is that something you want to do? COVID forced us to really have better modalities, and it pushed the field in the Caribbean to, at least a decade in quality of care and acceptance by the patients. There was also safety in the operating cyberspace. We had to learn very carefully, very quickly and very carefully how to protect. I remember, CAFA was, and many times we were having meetings and very strange people were coming to our meetings. So we had to prepare. We had to prepare patient information. We had to protect patient information. You all have to think about reduction of the risk of cybercrime, the hackers, the ransom specialists, and the bombers. Has COVID-19 done anything for the practice of public health? Well, we know it did impact on tourism, and we saw empty hotels, and this then impact on our bread and butter, because tourism, especially in the Caribbean, a wide sector of our workforce was, being through the tourism sector, and therefore the economies and our economic sustainability was being impacted. But what about health security, emergency, and response? What has COVID-19 showed us? It showed us that, we need to work together. So we had a coordinated response, a cluster from the Caribbean, which is the impacts, regional security sisters, and the Caribbean disaster management agencies. It taught us we need to work together. So for instance, very early when all our region was locked down, we had to get these samples to CAFA. No planes were flying. So you see these little planes, these impacts on the regional health security system, they came into being. And then they worked towards, we call them our heroes in disguise, because they were going around to the countries getting the samples. So it really speaks that we need to collaborate with our regional partners and our external partners with UE and with OECS and PAHO to show that real-time response. And, this is some examples of how we coordinated and bring vaccines and supplies and so on. And how, another example, how we employed this whole of society approach. This is us, our executive director, at the heads of government meeting. And also, if you notice, a different type of agencies are there, AFD and UKHSA and CDC and so on. but it really required coordination with the different agencies as well. So our confirmed cases are now decreasing, which is great. Knock on wood, hope that continues. But we cannot relax. We have to keep at it so that we don't have a resurgence, because we see that the variants are occurring. We see from our genome sequencing data, we see Omicron and new subsets or subvariants of Omicron still happening. And while all that is happening, we see new and resurgence of other illnesses. So we have to be very, very careful. We need to strengthen our health systems. We need to ensure our surveillance, our biosafety, health security, vaccination, communication, tourism and health, our capacity building for our laboratory and environment and epidemiologists, that they are all working together in a strengthened, coordinated fashion. COVID-19 proved the power of regionalization and the Caribbean solidarity in a crisis, and how the interpretation of political mandates of heads of governments can really bring life-saving actions. And that the Caribbean region needs this, not some of the time, but all of the times, even in ordinary times. So my take-home message is that whenever we are thinking about responding to any type of public health emergencies, think about a coordinated, multi-sectoral, multifaceted approach. And, you know, we have been given praise. The Caribbean did a good job of defining the essence of the pandemic, because it came down to finding that balance between lives and livelihoods. And we did well. Partnerships, this is some slides that shows partnerships created great and long-lasting dividends. But there is much more to be done. We know that climate change is impacting and will continue to impact. We are so small, and we have seen that, you know, we are now in the hurricane season. We have seen the impact of the hurricane season. Vaccination and the lack of vaccination is going to be a problem. How do we promote vaccination, especially in this era of vaccine hesitancy and, you know, of all the negative publicity that is happening on the worldwide web? How do we shift? How do we shift to improving tourism, but not just tourism, but safe tourism? So we see that the world is so fatigued, we call it COVID fatigue, that they have started to travel again. So these are some excerpts. The Caribbean rapid tourism recovery continues, and, you know, destinations are increasing. But do we want to ensure, how do we ensure, while all this increase is happening, that we are protecting and we are showing safe tourism? Air travel then and air travel now. How do we stop infections? Do we keep wearing masks and how do we reduce that risk during travel? So just because we are a small region, it does not mean that there is no public health excellence. The effectiveness of our regional organizations like CARFA can be harnessed to implement pilots of new and global initiatives for surveillance and alerts in countries of different sizes and complexities of health system. I'm coming down to my last few slides. What's next? We need to have joint and to continue joint working together. Joint procurement. We have to keep blunting the curve. We have to keep testing. We have to keep respecting the science. And I know it's a hard thing, but we need to balance between saving lives and livelihoods. We need to keep explaining COVID-19 and other public health emergencies, and overcome this infodemic and demystifying COVID. And we need to understand that, you know, we will have to live with COVID-19 like how we have living with influenza and other new bugs. There are different scenarios that spells trouble for the fall. These new variants that are looming and warning. There is the whole issue of the experts are now saying there could be a twindemic of COVID-19 and flu. And of course, vaccine and the use of vaccine and what will be the impact of that. Currently, we see that there's a 35% increase of global reported deaths from COVID-19. Some CARFA member states continue to experience increase, but we have returned to normality. And as you see, we are all going back into mass gatherings. We love our party, we love our mass gathering. So we have to continue to be vigilant while we do all of that. So that we do not, you know, encourage, or we do not contribute to another crisis, because COVID-19 is not done with us. So we have to continue with our masking. We have to look at climate change and the possibility that this will impact on our pandemic. We have to try to improve vaccines, the use of vaccines, and reduce vaccine hesitancy. We have to look at the other public health threats that are coming. From where we are seeing an increase in gastrointestinal illnesses. We are seeing new influenza strain. Well, with the rainy and hurricane season, we have seen that, we have had hurricanes, and what came with that is increase for vector-borne diseases, foodborne disease, and natural disasters. And of course, we now see that the cruise ship season is starting back. So there's that increased risk of travelers' health when tourism season continues. We are doing a holistic approach of enhancing our systems. We're enhancing real-time systems. So this is how we work with Bahamas and the rest of our Caribbean countries. We're strengthening syndromic surveillance and event-based surveillance. We have real-time systems of reporting for visitors in the accommodation setting or land-based, as well as in the sea-based setting. We want to develop systems, but whatever we report, that is accessible in real time to the country so they're aware. We're strengthening our laboratory work. Just this week, we had, a visit from the Public Health England that strengthened our capacity, and we can now do 3,200 samples at a time. We're working with our agencies. We are coordinating with our chief medical officers, and we are working towards regional health security. And this is my last slide. This is the way forward. It all comes down to building regional health security and having a framework. And we started that process by meeting with our chief medical officers, our national epidemiologists, our lab directors, our chief environmental health officers, and our partners to really chart a pathway forward. So this is my last slide. I want to thank everyone for giving us time to present at this meeting.
Thank you, Dr. Indar. You did mention that you have a meeting at 2 o'clock. Are you able to take it one question, or you will have to?
Yes, I could take one quick question.
Excellent. Do we have any questions there? I'll ask our support to keep an eye on the hands. Going once.
I'd like to ask a question. This is Dr. Mortimer Moxie. At the regional level, how do you link with FAHO and their work?
Yeah, that's a very good question. So before we were CAREC, we were CAFA. Before we were CAFA, we were CAREC. So we were part of PAHO. Now PAHO is one of our partners. So we work very closely with PAHO in everything we do. So they are part of our regional coordinating mechanism for health security. They were part of our pathway development. We share data. We try our best to, to do joint missions when we can. And, coming up very soon, November 1 in Barbados, we are going to a joint planning mission. So, it's a work in progress, but yes, we continue to work together.
Thank you. Excellent.
Great. So may I take my leave?
Yes, thank you very much.
Yes. Thank you very much for having us.
You're welcome.
Bye.
Yeah. All right, so if you have any remaining questions, you are invited to send it to Dr. Halliday or the other organizers, and they will seek to get a response to you. So we will now return to the initially shared order of the agenda, which are the remarks. Bringing remarks today on behalf of the Minister of Health and Wellness, Dr. Michael Dowell, is Acting Chief Medical Officer, Dr. Sharita Moxie. Minister Dowell had originally planned on being a part of the session, but he is presently on duty travel with a team from the Ministry, Department of Public Health and Public Hospitals Authority. Dr. Sharita Moxie is a medical physician and a public health specialist presently leading the work of the Health Policy and Planning Unit of the Ministry of Health and Wellness, which is attached to the Office of the Chief Medical Officer. Dr. Moxie has held numerous leadership roles in regional and international health fora, including serving as Vice Chair of the Strategic Advisory Group for the Pan American Health Organization which had the responsibility for setting the health agenda and roadmap for the region of the Americas for the period 2020 to 2024. She has recently been appointed to the Expert Panel Review Committee for the International Health Regulations in Geneva, Switzerland. Dr. Moxie has authored the publication titled The Bahamas' Physician Workforce Today and Tomorrow, as well as co-authored an article on the 2021 publication of the International Journal of Bahamian Studies entitled Public Health Policy in the Bahamas, an Overview. She has served as principal investigator on a number of NCD-related population-based surveys in the country, studies related to the role of technology in health, and studies to explore the biological and behavioral characteristics of men who have sex with men. She is a wife, mother of 2 talented children, community-oriented, and steadfast in her faith. Colleagues, you will now listen to Dr. Sharita Moxie, Acting Chief Medical Officer, who is bringing remarks on behalf of Minister of Health and Wellness, Dr. Michael Darby.
Ladies and gentlemen, good evening. The Minister of Health and Wellness, Dr. Michael Darby, extends warm greetings to each and every one of you. A previously scheduled regional engagement precludes his presence here with us this evening. I am Dr. Sharita Moxie, Acting Chief Medical Officer, and will bring brief remarks. This conference marks 16 years of excellence in national research since the inaugural conference in 2006. Then, its objective was to facilitate the improvement of health for the people of the Bahamas through clinical research to produce valuable knowledge for the prevention and management of diseases and the formulation of health policies and programs. Now, in 2022, you have not lost sight of that objective and have in fact solidified the value proposition of these annual conferences, not only by the quality, breadth, and relevance of research being shared in these spaces, but also because of the expanded network and collaboration with other respected research centers and researchers in the regional and international communities, as evidenced in your menu of presenters. Under this year's theme, Resilience in Healthcare Delivery, it is anticipated that the research intelligence flowing over the next 3 days catalyzes renewed commitment and that a sense of urgency will emerge. Resilience represents a relatively new concept, which is still insufficiently clear despite its increasing utilization in everyday speech and among various professions. The term was taken from technical sciences and first introduced in the fields of psychology and psychiatry. Many researchers agree that resilience is a very complex phenomenon and cannot be regarded as a one-dimensional construct. Nonetheless, resilience has been distilled to the capacity of a system or person to successfully adapt to change, to resist the negative impact of stressors and avoid occurrences of significant dysfunctions, and to learn from shocks, thereby minimizing risk and vulnerabilities to future shocks. Ladies and gentlemen, the recent and great shocks of our time were Hurricane Dorian and the COVID-19 pandemic. Without contradiction, we know that combined, these shocks severely tested our health systems, threatened to damage the global economy, and amass a human cost far beyond the impact of any single disease. The magnitude of these shocks is incalculable. The indirect and intangible costs to social, health, including mental health, and national development domains may never be fully understood. And although the challenges were new and the losses immense, the resilience was and continues to be undeniably remarkable. Ladies and gentlemen, our collective resilience in the health sector during these shocks manifested as configuring and reconfiguring physical spaces to manage COVID-19 patients while simultaneously preserving capacity to treat patients with other diseases in need of our care. It manifested as scaling up testing, tracking, and tracing capacity. It manifested as a shift to more digital and technology-based modalities to improve service delivery and system functions. It manifested as significant adjustments to staff schedules, roles, and workloads. Medical, dental, and nursing students continued their studies, graduated, and joined the healthcare workforce. They joined the front lines. It manifested as new policies and protocols and as leverages with the international community and agencies. Even your attendance at this research symposium speaks to your resilience, as it reflects a deep resolve for knowledge sharing to sharpen clinical skills and acumen, for driving innovation, and for connecting with others. These and so many more are highlights of our resilience. The undercurrents across these manifestations have been the indomitable spirit, unwavering courage, and sacrifice of our healthcare workers. No matter what divides us, gratitude for healthcare professionals for their titanic work is one thing that binds us together. Without you, our resiliency story would not be possible. But ladies and gentlemen, resilience is not an endpoint, it is a journey. Looking at the enduring system strains and stresses such as population aging or increasing incidence of multi-morbidity, now more than ever, we must embrace resilience as a dynamic objective for health system strengthening. There is much work to do on many fronts. The tenuous workplace morale, the unabating rise in the prevalence of non-communicable diseases, and premature NCD deaths, significant slippage in the national immunization coverage rates, the rise in antimicrobial resistance, new and emerging public health threats and communicable diseases, climate change and its impact on health and well-being, the infiltration of substandard, falsified, and counterfeit medicines into the local market, the maldistribution of healthcare workers, concentrating many needed health providers in New Providence, leaving our Family Island communities vulnerable. And let's not forget the suboptimal quality control systems for assuring food quality and food safety, especially considering our high food import bill and the nexus between diet and health. Ladies and gentlemen, as I close, I take this opportunity to recognize Dr. Cinqui Brown, who was recently appointed Director of the UWI Bahamas campus. As you continue to drive academic excellence and enrich the field of medicine, it is hoped that research is elevated as the bedrock of our forward actions to shed light on specific health characteristics among our people, shaping national policies and national interventions. Ladies and gentlemen, the Bahamas stands proud of the growth and the development of the University of the West Indies School of Clinical Medicine and Research since its establishment in 1997. And it is indeed an honor for me to mark this moment in history and your continued growth. I extend best wishes and on behalf of the Minister to you and every success in this year's conference. Thank you.
We would like to thank Dr. Moxie for those remarks. And then move on to our other presentation. We will now receive remarks on behalf of the University of the West Indies. Dr. Corinne Cinqui Brown remains the only pediatric hematologist oncologist in the Bahamas and has steadily built a sterling reputation in her field. A graduate of the University of the West Indies School of Medicine, she pursued and completed residency training in New York and New Jersey in the United States, but returned to the Bahamas immediately following her completion of a fellowship training at the University in 1991. Board certified in pediatrics and pediatric hematology oncology, and a lecturer in child health for the University of West Indies, Dr. Sinqui is involved in postgraduate training in pediatrics and family medicine. She is a member of a number of local and international medical organizations, maintaining important links with many of the US and Canadian colleagues to facilitate ready access to current treatment protocols. Dr. Sinqui is regarded as one of the field's active leaders in the Caribbean region. She plays an active role in the Sick Kids Caribbean Initiative, serving as co-lead physician for the Caribbean. She espouses that the initiative is an important project in the pooling of resources and working together to improve the quality of care in cancer and blood diseases for our children in the region. Her role in the initiative has broadened her involvement at an international level, as she is part of the PAHO Childhood Cancer Working Group and the Bahamas National Coordinator to the ASH Children's International Consortium on Acute Leukemia, CCAL. She has been appointed a member of the American Society of Hematology International Members Committee for 2022-2025. As a strong, internationally respected advocate for children with cancer and blood diseases, Dr. Corinne Sinqui also serves as medical advisor to local sickle cell and hemophilia awareness civil society groups and is involved with the Cancer Society of the Bahamas Screening Assistance Program. In August 2022, Dr. Sinqui Brown was appointed Program Director of the University of the West Indies School of Clinical Medicine and Research in the Bahamas, as the leadership baton was passed following the retirement of Dr. Robin Roberts. In her appointment, Dr. Corinne Sinqui was lauded as an undoubted leader in the medical process and in her area of specialty, not only in the Bahamas, but also regionally and internationally. We will now receive remarks from Dr. Sinqui in her capacity as Program Director. Dr. Sinqui.
Thank you very much, Dr. Swan, and I'd like to thank Dr. Sharita Moxie Ingra for bringing kind remarks from the minister who unfortunately could not join us. It is indeed 16 years since we started the Research Day presentations under the leadership of Professor Howard Spencer, and that's around the time that we started the School of Clinical Medicine and Research. We celebrate 25 years of being in existence, where the Bahamas became a training site for 4th and 5th year medical students. And next year, we will be celebrating the 25th anniversary for us, the 50th anniversary of independence for the Bahamas, and the 75th anniversary of the University of the West Indies. So we do plan to have some good celebration fireworks going on for next year. But going back to Research Day though, it is 16 years of uninterrupted presentation of our work. I did not retire one of the years, the year that we were not able to deliver because of COVID. And I kept that one to call that the ghost year, the ghost of COVID. And so we are still going to count it as a continuation for 16 years. We chose resilience in healthcare delivery, and I think Dr. Sharita Moxie spoke very well about what that means. She talked about how it means establishing and building a foundation to effectively and efficiently deal with a crisis, but that it also ensures that you have to reflect on lessons learned to reorganize and refashion how we navigate for the next crisis. Dr. Indar, in her speech as a representative from CAFA, spoke about establishing partnerships as being an important link in the management of a crisis, because no one is an island, and oftentimes the crisis is not an isolated event, just affecting you and not your neighbors. So this is an important thing that we do. More important than anything else is that we take our responsibility as a university very seriously in being a part and the link to helping to bring what we have as ideas establish through research whether or not these ideas can in fact influence change for the better. And the university's mission is to advance learning, create knowledge, and foster innovation for the positive transformation of the Caribbean and the wider world. We have graduated 600 medical students from this site so far, and 131 specialists in our DM programs. It is good that part of the DM program requirement is indeed research. And it is in this forum of Research Day that we oftentimes have the opportunity to have outcome of the research presented, not just for a paper put aside in the library, but actually to share with the wider community and hopefully with the policymakers to make meaningful change to better the delivery of healthcare. I'd like to personally thank the Royal Bank of Canada, who actually stepped forward and supported us for the first 15 years of our delivery of Research Day. We now have called upon the partnerships that we have with our key stakeholders, the Ministry of Health, the Public Hospital Authority, the Medical Association of the Bahamas, and Physician Alliance to help us to underwrite some of the funding for the delivery of this Research Day in the form of a meaningful sponsorship and to allow us to be able to continue to do what we do best, which is to share information at the least amount of cost for the majority of people. So right now, as it has been always, the cost to attend these upcoming days is free. We have, in fact, assigned CME credits for the activity, so that is a possibility to be had, and this has been an important forum to gain CMEs in order for you to get licensed. I am hopeful that you will find the information over the next 3 days very, very enlightening. We do have other keynote speakers from PAHO and also the University of Miami and the National Medical Ethics Committee and our own local faculty who will discuss things like building resilience through transformation of health systems. We heard about the impact of COVID in the region, access to future health medicines for patients, patterns and trends in certain cancers, the barriers to research, and how to prepare manuscripts for publication, and the opportunity for collaborative research. But the highlight for me is to listen to our residents and medical students present their own research. So I'm very excited about how we have put this together, and we have put it in small bits and small pieces. It's over 3 days. It will be only approximately about 2 hours a day, and we are hoping that you will all join us. I see so far that we have already 149 attendees to this conference, and I'm hopeful that that number will even mushroom to much more. Welcome to Research Day on behalf of the University of the West Indies, and in particular, this School of Clinical Medicine and Research. Thank you very much, Dr. Swan.
Thank you, Dr. Sinkri. Okay, so now we'll turn our attention to the remainder of our sessions, focusing on our presenters, residents, and recent completers, I guess you can call it, of your DM programs. Our first presenter in that regard is Dr. Rokisha Claire Klein-Busink. She obtained her MBBS in 2004 from the University of the West Indies in Trinidad. She then pursued training at the Welsh Institute of Dermatology at Cardiff University School of Medicine in Wales in the United Kingdom, where she obtained a diploma and a master's of distinction in clinical dermatology in 2010. Dr. Claire Klein-Busink returned home in 2010 to resume working in the Department of Dermatology in dermatology and Department of Internal Medicine at PMH, and joined the teaching faculty of the University of the West Indies School of Clinical Medicine and Research as an associate lecturer in dermatology later that same year. She completed the Certificate in University Teaching and Learning course, CUTL, offered by University of the West Indies Mona campus in Jamaica in 2016. Dr. Claire Klein-Busink has supported the Ministry of Health and Wellness and the Public Hospitals Authority's telemedicine efforts as she anchored the Telederm Clinic since 2011. Based at the Princess Margaret Hospital, the Telederm Clinic provides services to patients accessing healthcare at public community clinics on Andros, Abaco, and Long Island. Dr. Claire Klein-Busink is currently pursuing her MD at the University of Cardiff in the United Kingdom. She will speak on the topic dermatological and other chronic conditions, impact of quality of life on patients and their family members in the Bahamas. Kindly listen to her presentation.
Dermatological and other chronic conditions impact on quality of life of patients and their family members in the Bahamas. I am Dr. Rakisha Claire Klein-Busink. Now, this quality of life study comprises two countries, the Bahamas. We are looking at dermatological conditions such as psoriasis, acne, eczema, hidradenitis suppurativa, as well as other chronic conditions, rheumatoid arthritis, diabetes mellitus, and chronic kidney disease. These two groups will be compared. In Cardiff, we're just looking at dermatological conditions, and we're going to compare those conditions to the dermatological conditions of the Bahamas. Now, the aim is to determine the impact of a chronic health condition on the quality of life of patients and their family members in the Bahamas, as well as comparing the impact of dermatological conditions on the quality of life of family members of these patients with that of family members of patients with other chronic conditions. Now, to do this, we have to measure quality of life in patients with chronic conditions, determine the impact on the quality of life of family members, correlate the quality of life of patients with that of their family members, and compare the quality of life of patients and family members of the two groups, dermatology and other chronic conditions. We attained ethical approval May 4th of 2021, recruited patients from February to April of 2022. We used children and adults from age 4 years and over, and family members from age 18 years and over, and we got 348 proud Bahamian participants using conveyance sampling. Now we have 6 quality of life questionnaires. From 16 is the main quality of life questionnaire that can be used across all medical disciplines. It is a generic health-related quality of life instrument that measures how a family member's life is being affected by their patient with a chronic condition, as well as it helps to support areas that may be in need of further care. Scoring goes from 0, not at all, a little at 1, and a lot at 2. Scoring range goes from 0 to 32. Now we have other quality of life questionnaires that are more dermatology specific. Dermatology Life Quality Index, DLQI, Family Dermatology Life Quality Index, FDLQI, Children's Dermatology Life Quality Index, CDLQI, and there's 2 of them, this text version and my favorite, colors. Then we have for other chronic conditions, the WHO brief, World Health Organization Quality of Life brief, which has 4 domains that we look at: physical health, psychological, social relationship, and environment. For the children, we have the Revised Children's Quality of Life Questionnaire, Kindle, and these have 3 versions: a kiddie at 4 to 7, a kiddo at 13 to 16, and a kid at 8 to 12. Now, when we want to look at our results, we said that dermatological arm had 90 participants. 11 were children that completed the CDLQI, 34 were adults that completed the DLQI, And the family members, 45 of them completed the from 16. At that moment, how is my life being affected? And the FDLQI. During a month's period, how is my life being affected? The adult mean DLQI score was 8.41, which gave them a moderate impact. The family member from 16 was 3.53, and the family member FDLQI was 3.02, showing a small impact on their quality of life. However, inferential statistics showed DLQI with FDLQI during a month, how was my quality of life being affected, was strongly positively related. DLQI with from 16, at that moment, how was my quality of life being affected, had a weak relationship, but not significantly statistical. FDLQI with from 16 showed a strong positive relationship. As it pertains to children using the CDLQI, they had a 7 mean score, which indicated moderate impact. Their family member of from 16 showed 3.1, and their FDLQI family member showed 3.6, also giving a small impact on their quality of life. However, inferential statistics showed CDLQI with FDLQI during a month, how was my life affected? CDLQI with from 16, at that moment, how my life is affected, had a strong positive relationship. And the FDLQI with the from 16 had a strong positive relationship. So now, as we move on to other chronic conditions, we had 258 participants. 4 children completed the Kindle, 125 completed the Football Brief, and 129 family members completed the from 16. At that moment, how is my quality of life being affected? The mean score was 56.4, showing an average impact on their quality of life. Not significant, not poor. The from 16 family member showed a 6.26, small impact as well on their quality of life. The Who Crawl Brief and from 16, when looking at inferential statistically, showed a weak negative relationship on their quality of life. And when we looked at the Who Crawl Brief Domain 1, physical health with from 16, that also showed a weak negative relationship on their quality of life. Now we say how we can use these from 16 scores to determine any impact. Now from 16, when we're ranking them, we're looking at what is the most impacted to the least impacted. And we had a top 8 most impacted that was very similar between the two, just in different orders. And we found 2 different ones, Q9 for dermatology, my eating habits are affected, and Q8 for other chronic conditions, my everyday travel is affected. So chronic conditions affect both patients and their family members. We found similarities between the 2 dermatology and other chronic conditions as it pertains to feeling worried, sad, frustrated, difficulty caring for the family member, family activities being affected, increase in expenditure, and sleep was affected. Now, differences we found within question 9, everyday travel was affected for dermatology, and question 8, eating habits were affected for other chronic conditions. Dermatology family members of pediatric patients experienced a greater impact on their quality of life using FDLQI during a month's time, how is my quality of life affected? And from 16, at that moment, how is my quality of life being affected compared to the family members of the adult patients? So from inferential statistics, FDLQI and from 16 were strongly correlated. So our family members are telling me, whether it's during that month or at that moment, my quality of life has been affected. So when we're looking at family members of other chronic conditions, we have adult patients experience less impact on their quality of life compared to the patient. And perhaps this can be that many of the patients don't want to be a burden on their family member, and therefore sometimes any bad feelings or changes that they may feel, if it's not significant, they may not say. Therefore, the family member going on what the patient is providing them with sees the patient as being okay and willing to tolerate what's happening with them, and therefore the family member goes on with their daily life. So, validated quality of life questionnaires are useful in measuring impact on the quality of life. Patients and their family members of both groups experience similarities of impact on their quality of life. Dermatology family members of pediatric patients experience a directly proportional impact on their quality of life, like that of the patient. And other chronic condition family members of adult patients experience less impact on their quality of life than the patient. Thank you.
Our next presenter is Dr. Randa Dowell. Dr. Randa Dowell will speak to us on the role of diet, sex, and the microbiome in urine sterile osteomyelitis. Dr. Dowell.
Okay. I'd just like to thank the organizers of the Research Day for allowing me to take part and to present some of the research with which I was involved in while at the University of Iowa recently during my fellowship training. And I'd just like to give a brief overview today, if I may. And so this is just a general outline of what I will be discussing, and I will go through it as quickly as I can in the absence of time. So I just want to give a little bit of background about the condition which we were studying. It's called chronic recurrent multifocal osteomyelitis, or CRMO, and it's an autoinflammatory sterile osteomyelitis that affects children, though it can present at any time in life. And it causes an inflammatory disease of the bones, the joints, the skin, or even the intestines. And patients often present with bone pain involving one or multiple bones. CRMO occurs sporadically, but it's associated with other autoinflammatory conditions as well, such as psoriasis, inflammatory bowel disease, particularly Crohn's disease, which is what piqued my interest, or inflammatory arthritis. Patients or their family members often have one or more of these conditions, and this suggests that there's some pathogenic origin with regards to these conditions. And the inflammation often occurs in the absence of autoimmune or infectious disorders. And CRMO, though it was first described in 1970, to date, there's been no etiology defined or discovered or recognized. And so it still remains unknown. And research thus far has implicated genetic and immunologic and environmental factors in disease susceptibility. However, we have no diagnostic test. And inflammatory markers on testing are usually normal or maybe mildly elevated. And so that often results in a delay of diagnosis as well. It's a non-bacterial osteomyelitis, so your blood cultures typically are sterile, and it doesn't respond to antibiotic therapy. So patients are managed with anti-inflammatory medications, your NSAIDs, corticosteroids, some of whom respond, but often many patients do not. And so then they require things like TNF-alpha blockers or bisphosphonates, again, which may not manage or treat the condition. And so treatment of CRMO basically depends on chronicity, severity of the disease, and the overall clinical picture and basic research has suggested that it involves the innate immune system. And so it's classified as an autoinflammatory bone disease. Now, autoinflammatory disorders are innate immune system disorders, often involving dysregulation of interleukin-1 beta. And they present with recurrent inflammation, and often increased autoantibodies can be found on testing. As a result of the interleukin-1 beta dysregulation, many autoinflammatory disorders will respond to interleukin beta-1 blockade. CRMO, however, is complex, especially genetically, as several single genes have been identified as possible causative factors, and new genes continue to be identified. In addition, several mouse models have been developed. And in the mouse model, we have chronic multifocal osteomyelitis, or CMO, a very similar disease seen in the mice models. And the affected mice develop inflammation of their toes, their foot pads, paw pads, kinking of the tails, and they also develop a skin condition that looks very much like the human disease of CRMO. And so testing on these mice models have led to some of the information and the new advances that have been made in human CRMO disease. One of the main proteins that seems to be involved with pathogenesis of CMO in the mice is the PST-PIP2 gene, which you may hear me refer to going forward. And so a series of experiments were done trying to determine just etiology and what's the driving factor of disease in these CMO mice. And one particular group, Lukens et al., found that when they fed the CMO mice a high-fat diet, that the mice seemed to be protected from disease. And so they did studies whereby they tried to manipulate the microbiome and the fat content of the diet to see if it would then attenuate disease or even prevent onset of disease. When they did do that, they found that there was some protection across mice on high-fat diet, but they had looked at one particular strain of the CMO mouse. Now, why is all of this significant? Well, one, it may help to identify the pathogenesis of this osteomyelitis that we see in humans. It may also help to inform about the pathogenesis of other autoinflammatory diseases that we see in either CRMO patients or their relatives, and may ultimately help to guide treatment modalities for this disease. So in our lab, we went ahead and tried to replicate the studies that had been done with regards to the high-fat diet. And what we found, interestingly, was that high-fat diet does indeed confer protection, but it seemed that it only provided this protection to the female CMO mouse. And we see here on this graph, just where the solid red line is females on a high-fat, high-cholesterol diet, females on a high-fat, low-cholesterol diet, and females on a low-fat diet on this disease-free survival curve all had attenuation of disease while on the high-fat diet, whereas the males continued to develop disease as they had on a regular diet. And so this then, we figured maybe it was because of the strain of mouse that was used. And so we divided it up into different strains, and we did the studies again. And we found that in the, let's see what mice here. We found that in the BOLB-C mouse model, that females were indeed protected, but attenuation of disease was not as strong as we would have predicted based on giving them a high-fat diet. The females were indeed protected, as evidenced by this the solid pink line, but the other strains, other genders on other diets, including a high-fat diet, did not really have statistical significantly difference in terms of disease onset and rapid progression of symptoms. We tried another strain of mouse to see if there would be any difference there. And what we found was that the CMO mouse model on the high-fat diet did have delayed onset of disease compared to those on the standard mouse chow. However, again, there wasn't that strong difference that we had noted with females in the initial studies. And so it seemed like there may be some differences between the strains, but again, we didn't have an answer as to why initial studies showed that the females were protected. And so then that led to the question of what is the role of diet and sex in this sterile osteomyelitis? And we divided the project into two arms, where the first arm, we looked at the role of sex, and especially male hormones, which were more easily manipulated in our project. And we wanted to know what is the role of the male hormones in susceptibility to this disease. And if we could manipulate the level of hormones, can we then modulate disease susceptibility? And so we performed castration and sham castrations on two groups of mice, CMO males, placed them on a high-fat diet, and we had anticipated that castrated males with lower testosterone levels would then respond like females while on the high-fat diet. And so that was our working hypothesis. So they were fed the high-fat, high-cholesterol diet, those who underwent the actual castration, those who underwent a sham castration. And then we compared those two groups to each other, as well as two mice who were on a standard chow, to see how would disease progress in these various groups. And again, we had anticipated if testosterone is driving this disease, then those on a high-fat, high-cholesterol diet who had been castrated should be protected from disease. We had a validated scoring system where we did phenotypical examinations, looking at the tails, the toes, and the paw pads of these mice. And we used the scoring system to determine onset and severity of disease. Again, we used two different strains of CMO mice. And in one strain, the bulb CMO mouse, we found again that compared to those on a standard chow, those who were on a high-fat chow did indeed have delayed onset of disease, but they did develop disease. There was some attenuation of disease in the mice who had been castrated, but there wasn't a strong castrations or those who were simply on a high-fat diet. We looked at another strain of mouse, again, in whom we had done castrations versus sham castrations. And while they, again, had delayed onset of disease compared to those on a regular chow, those who had been castrated did not show significant delay of onset of disease compared to the mouse who was on a regular high-fat diet. We did some immune analysis as well, just looking for markers of inflammation within the bone marrow cells. And there was some trend towards elevation of neutrophils in some of the groups, but again, not very significant in terms of between the two groups, the sham versus the castration, although they did have lower levels compared to those who were on a low-fat diet, for example. And so then we also wanted to know, what is the role of diet, sex, and the microbiome in the sterile osteomyelitis? Can we manipulate the microbiome? And would that then attenuate disease? And we wanted to know, is there a specific ingredient in the food that was maybe causing that initial sex-specific protection that we had seen with the females? And can we manipulate the microbiome to then confer protection to other strains of mice as well? And so what we did was come up with a fecal transplant project whereby we took the female CMO mouse who had been on a high-fat diet, who had then developed protection against the disease. We transplanted her healthy gut microbiome into young, unaffected CMO male pups. And the expectation was that with them receiving this healthy gut microbiome, they would then have delayed onset of disease. Conversely, we then took CMO mice who were on a low-fat diet, males and females, who were then thought to have pro-inflammatory gut microbiota, and we transplanted their feces into unaffected CMO pups with the expectation that they would then have acceleration of disease, having received this pro-inflammatory transplant. So we did twice-weekly gavages, and again, we monitored them for 14 weeks, checking twice a week for any phenotypic expression of disease. And like with the first project, at the end of the time, we collected further tissue samples for other analyses, including the immune analysis as well. What we found with the fecal transplant study was that looking on this disease-free survival curve, that those who had received fecal transplants, the dotted lines, we see that they do have some attenuation of disease, but again, not statistically different from those who are on a high-fat diet. And in fact, the females on the high-fat diet actually seem to have earlier onset of disease compared to those who had received the fecal transplants. We did the second strain of mice as well. And again, the females just on the high-fat diet, that solid pink line, were protected. But those who had received the fecal transplants, they did not achieve that level of protection or the attenuation of disease that we saw in the females. Again, the males on the high-fat diet continued to develop disease at the rate that we would have expected, but we did not see the attenuation of disease in either of the groups who had received the fecal transplants. When we looked for immune cell changes in these groups as well, and we looked at both recipients and donors, we saw that in the female recipients that they tended to have slightly increased numbers of immune cells, suggesting that there was a trend towards developing disease after having received the male microbiome. But again, it did not play out to give us statistical significance once analyses were completed. We looked at organisms within the microbiome itself. Previous studies had shown that in autoinflammatory disorders and in the CMO model in particular, Prevotella in the gut seemed to be one of the pro-inflammatory markers or pro-inflammatory organisms, but we did not find that when we did analysis of our fecal samples on our donors, our recipients, comparing them to each other, there wasn't that much of a difference in terms of the gut microbiome. And so in conclusion, we do know that based on previous research and study, dysbiosis may play a role in sterile osteomyelitis. However, there are other factors such as diet, genetic background, or sex, which may also play a role in disease. And clearly further research is needed to determine the exact role of the gut microbiota. If there is a specific diet component which will modulate this disease, then hopefully that can be translated into a treatment for CRMO itself. And clearly identification of the genetic etiology, molecular mechanisms for CRMO is needed just to help with guidance of coming up with diagnostic markers as well as adequate therapy for these patients. And I think that's all that I have on my references, and thank you.
All right, thank you, Dr. Dabo, for your presentation. At this time, we'll open the floor for any questions. All right, there being none, thank you once again, Dr. Dabo, for your presentation. The next topic is going to be presented by Dr. Diana Bannister, who was DM in internal medicine. And Dr. Bannister's topic is going to be the prevalence, risk factors, and the 30-day mortality among patients with acute kidney injury in the critical care unit at the Princess Margaret Hospital between 2014 and 2019. Dr. Bannister.
Good afternoon, everyone. My name is Dr. Diana Bannister, and it is my pleasure to be participating in this year's Research Day. And so my research focused on the prevalence, risk factors, and 30-day mortality among patients with acute kidney injury in the critical care unit at the Princess Margaret Hospital over a 6-year period. And so just for a little bit of background, acute kidney injury can be described as a sudden decrease in glomerular filtration rate that results in the retention of metabolic waste products and the dysregulation of fluid, electrolyte, and acid-base homeostasis. The global burden is estimated to be 13 million people per year. And of that, it affects 20 to 50% of patients who are admitted to the critical care unit. Acute kidney injury is associated with poor clinical outcomes and high mortality, and studies have revealed a 1.4 to 3.2-fold increase in mortality among this particular patient population. And in one large prospective cohort study that was done in Denmark, it showed that among critically ill patients with acute kidney injury, mortality was revealed to be 41%, compared to a mortality of 12.8% in persons without acute kidney injury. And so with the burden of kidney disease in the Bahamas, we thought that it was important to assess the impact of acute kidney injury on our own local burden and to see how it affects our own population. And so with regards to our research, we conducted a 6-year retrospective chart review between 2014 and 2019, assessing the epidemiology of acute kidney injury in critically ill patients 18 years or over, admitted to the Princess Margaret Hospital. The SunQuest Integrated Clinical Environment ICE system at the PMH was assessed and utilized for collection of biochemical data. Patient medical charts were accessed for clinical and medication data, and dialysis logbooks in the critical care unit were accessed for information regarding the receipt of renal replacement therapy. Descriptive and inferential statistics were generated for variables of interest, which included age, gender, comorbidities, the presence of sepsis, hospital acquisition, community acquisition, the receipt of renal replacement therapy, and 30-day mortality. So our objectives were to identify patient demographics with regards to age and gender, and to identify comorbidities associated with acute kidney injury in the critically ill patient population. We wanted to identify the prevalence of acute kidney injury in the adult critically ill patient population at the Princess Margaret Hospital, to identify associated 30-day mortality proportion, to identify the risk factors associated with acute kidney injury in the critically ill patient population, to identify critical care patients with community acquisition versus that of hospital acquisition. And so we hypothesized that a large proportion of patients with acute kidney injury in critically ill patients would be younger than 65, they would be male, and they wouldn't have any comorbidities, that the prevalence of acute kidney injury would be at least 30% in our unit at the Princess Margaret Hospital, that the 30-day mortality proportion would exceed 50%, that sepsis would be the main etiologic risk factor, and we expected that there would be a greater proportion of hospital acquisition versus that of community acquisition. And so this is just a table showing some of the components of the study design. As I mentioned, a retrospective chart review. Patients were 18 years and over. At the Princess Margaret Hospital, our sample size was 549 adult patients admitted to the critical care unit. And we measured various biochemical and clinical parameters, which included serum BUN, creatinine, white blood cell, urine, blood, CSF cultures, blood cultures, comorbidities. We looked at blood pressure, urine output, the use of nephrotoxic agents, the use of renal replacement therapy, the need for mechanical ventilation, and the use of inotropic drugs. And we utilized descriptive, inferential, and multivariate statistics for our analysis. And so what did our study reveal? So our study revealed that the cumulative prevalence of acute kidney injury in our patient population was that of 24.2%, approaching 30% at the end of the study. And this was found to be a statistically significant finding over the 6-year period of the study. And here we have a pie chart showing the distribution of acute kidney injury based on stage of acute kidney injury. And so we see that 52%, or the majority of persons, had stage 1 or mild acute kidney injury, followed by 29% of persons with stage 3 or severe acute kidney injury, followed by 19% of participants with stage 2 or moderate acute kidney injury. And here we have a chart looking at the 30-day mortality proportion, again, based on the stage of acute kidney injury. And I should add that the stage of acute kidney injury is based on the guidelines by the KDIGO group. And so here we see that among participants with stage 1 acute kidney injury, they had the greatest number of persons overall experiencing 30-day mortality, numbering 128, which was 44.6% of persons in that group. However, if you look at persons with stage 3 or severe acute kidney injury, that group had the greatest percentage of persons experiencing 30-day mortality, numbering 72, but at 45.9%. And so we think that in the stage 3 acute kidney injury group, that likely reflects the greatest severity of disease burden and severity in that group. We do note that this was not a statistically significant finding, but we know that mortality was approaching 50% during the study period, which is what is commonly cited in the wider literature. And here we look at another pie chart just showing the frequency of the distribution of acute kidney injury based on acquisition. So we found that 53% of persons had community acquisition of acute kidney injury. So when they presented at the hospital, they had acute kidney injury or they developed it within 48 hours of admission. And 47% of persons had hospital acquisition of acute kidney injury, meaning that it occurred 48 hours after admission to hospital. And here, this is a chart looking at the 30-day mortality proportion based on acquisition. And so among persons with community acquisition, we see that 118, which represents 40% of persons in that particular group, experienced 30-day mortality compared to 128 or 49% roughly of persons with hospital acquisition experiencing 30-day mortality. And this again was found to be a statistically significant finding. And based on with regards to gender distribution, we found that 53% of persons were male and 47% of persons were female in our study. And if we look at 30-day mortality based on gender, we see that when it came to males, 134 or roughly 46% of male participants experienced 30-day mortality versus 112 or 43% of female participants experiencing 30-day mortality. However, this was not a statistically significant finding. And then when we look at the frequency of renal replacement therapy based on the stage of acute kidney injury, we see that persons with stage 3 acute kidney injury had the greatest proportion of persons requiring renal replacement therapy. And again, this reflects the severity, the burden and the severity of disease in this particular group. And it makes sense that this particular group would have required more renal replacement therapy as compared to persons with stage 1 or stage 2. And this was also found to be a statistically significant finding in our study. And again, and here we're looking at the frequency of renal replacement therapy based on acquisition. So among persons with community acquisition, we find that approximately 21% of persons with community acquisition require renal replacement therapy compared to 22 or 8% of persons in the hospital acquired group requiring renal replacement therapy. And so this may reflect that persons with community acquisition were likely coming in more ill, were more severe in terms of their clinical presentation. And that was a statistically significant finding in our study as well. And here we have a chart that looks at 30-day mortality based on age stratification. And so if we look at the 65 and over age group, we see that that had the highest proportion of persons experiencing 30-day mortality. So 83 persons, which was 47% of persons within that group. However, it should be noted that overall, 2/3 of persons who experienced 30-day mortality overall were less than 65. So mortality was still higher in the persons under the age of 65. But this was not a statistically significant finding. And this is just a table looking at different patient characteristics, again, stratified based on the staging of acute kidney injury or its severity, mild, moderate, or severe. And so just to summarize the core results of our study, we found that the mean or average age was 54.8 with a slight male predominance. The prevalence of acute kidney injury approached 30%. We found that the large majority of persons had stage 1 or mild acute kidney injury, followed by stage 3 acute kidney injury, followed by stage 2 acute kidney injury. And we found that the prevalence of community acquisition was 53.2%, and that of hospital-acquired acquisition was 46.8%. We noted that renal replacement therapy was administered in 84 or 15.3% of all patients within the study, and that sepsis was present in 150 or 27.3% of participants in the study. And we noted that 30-day mortality was 44.8% overall for the 6-year period of the study, which again is approaching 50%, which is usually cited in the literature, in the wider literature. And so in conclusion, The study highlights that the prevalence of acute kidney injury and its associated 30-day mortality was high in our critically ill population at the PMH. And it really should galvanize us to take on efforts to conduct long-term follow-up and monitoring of these patients as it relates to mortality, and particularly as it relates to progression to chronic kidney disease. And I'd just like to acknowledge Dr. Adrian Sawyer and Dr. M. Anthony Frankson, who were tremendous helps and guidance in conducting this study. And these are my references. Thank you very much.
Thank you, Dr. Bannister, for
Yes, sir.
the discussion.
Mhm.
We're gonna open the floor for questions. But before we take the first question, I have one or two for you.
Yes, sir.
I may have missed it on the slide, but I'm sure I didn't hear you say it. What is the N of persons? How many persons were it that actually had or were identified as having acute kidney injury during the time period?
Mhm. Okay, so we had a sample size of 549 persons. So it was 549 persons who we identified as having acute kidney injury. And we then stratified those persons based on acquisition, whether it was hospital acquired or community acquired. And then we further stratified it based on whether it was stage 1, stage 2, or stage 3.
And last question, was there
Mhm.
a removal of the confounder or potential confounder of chronic kidney injury?
Yes, so we did remove persons. So persons who had chronic kidney disease, persons who were already on or receiving dialysis were not included in the study.
But no idea of how many persons that was.
No, I can't say at this time. It was a huge number, quite a bit, but I can't remember at this time specifically. Mhm.
Thank you.
No problem.
Any other questions for Dr. Bannister? All right, can you just go over that recommendation slide again for us, please?
Okay. Right. So with regards to the recommendations, and I can actually point out some that I don't have on the slide. As a result of the findings of our study, we had several recommendations that we put forth. One would be to have a follow-up clinic specifically for persons who experience acute kidney injury in the critical care unit. So having a specific focused clinic looking at follow-up and looking at longer term outcomes. So we looked at 30-day mortality, but we can also look at 60-day mortality. We can look at 1-year mortality and see how these patients fare. And so having a targeted follow-up clinic for these patients was one of the recommendations. Another recommendation also was having better risk stratification tools for clinicians when patients actually come into hospital, so that we can actually identify these patients earlier. And if we identify them earlier, then we can start to facilitate management, preventative treatment, et cetera, et cetera. And so just utilizing risk stratification models that have been approved for in the hospital, and also for risk stratification models for persons working in the community as well. Because we found that, through my review of the literature, we found that a lot of persons experience severe acute kidney injury and subsequent morbidity mortality when acquisition occurs in the community. And oftentimes these persons, there is delay for them to receive medical treatment. They tend to be much more iller when they do present. And so if we can get clinicians in the outpatient setting to also adopt risk stratification tools and models to identify these patients as quickly as possible, that would also be helpful as well.
Thank you. And we definitely reach out to you to discuss more on your findings, because this is one of the areas of Department of Public Health is focusing on and trying to reduce, I guess you can say, the speed that our patients and our clients of our community transition from acute kidney injury to chronic kidney injury and renal replacement therapy.
Yes, sir.
Last call for any questions. And There being none, thank you very much once again.
All right, thank you.
Move on to the other presenter rather. Dr. Sasha Dorset, a family medicine resident, will present on the impact of the novel coronavirus infection on geriatric hospital patients, a retrospective review. Dr. Dorset.
Good afternoon to all. I'm excited for this opportunity to research the impact of the novel coronavirus infection on the geriatric hospital population. The research team for this project also consists of Dr. Ashley, Dr. Nick Albury, and Dr. Indira Grimes. There's nothing to discuss. And so just in an effort to ensure that the information that is shared is clear and understandable, here are some key terms that we utilized in the generation and execution of the project. An older person, according to the United Nations, is an individual 65 years and older. Population age refers to an increase in the median age of a population as a result of demographic transition. And we're talking about the decline in fertility rates and the rise in life expectancy. A long-term care facility, this case of this study, refers to the hospital that provides continuous care for seniors who may suffer from morbidities, injury, frailty, other limitations. Long-term care facilities involve a physician-guided team. COVID-19 infection was diagnosed in patients using the SARS-CoV-2 PCR test. Spectrum disease was characterized using the National Institute of Health's guidelines for the patient asymptomatic or has mild, moderate, severe critical disease. A persistent symptom is a symptom seen more than 4 weeks after it has cleared an infection. An individual who was once affected, cleared 4 weeks and recovered and became infected again. And so the motivation of the study was bifold and concerned not only the aging population, but the public health crisis, also known as COVID-19 pandemic that we experienced in our world. Population aging is an undeniable phenomenon with Caribbean and local relevance. Globally, the proportion of older people has increased, which means 1 in 5 people in the world is expected to be older than 60. And the Bahamas also notes this exponential growth or change in seniors. 2020, we see an increase from 3.5% of our population being senior, 7.0%. And so not only is the population rising, but this population was so greatly affected by the COVID-19 pandemic. Older persons are more susceptible to developing severe forms of COVID-19 disease due to higher rates of comorbid conditions. Older persons experience immunosenescence. They have the impaired immunoglobulin production, impaired signal transduction, loss of proliferative capacity of immune cells. And then we saw studies like the one done by Alonso Lana et al. Confirmed that it was the COVID-19 or the long-term facilities that specifically affected by COVID-19. And it's because people in long facilities are on open wards, are in close contact with each other, and they complete group activities together. And so the study was completed at the geriatric hospital in an effort to obtain more data on the Bahamian geriatric population and the healthcare burden that was increased by COVID-19. Study findings can be applied to evidence-based practice related to COVID-19 care for persons and be applied to initiatives and intervention persons in long-term facilities. The aim of this is to identify the older persons diagnosed with COVID-19 at the hospital and explore the impact of COVID-19 on health and wellness of these patients. Furthermore, the study worked to determine the prevalence of COVID-19 disease in the hospital, assess the spectrum of disease among those with the PCR-proven COVID-19 disease, to explore possible predictors of mild, moderate, and severe disease, to access outcome disease, and to investigate if there's an association between COVID-19 infections and severity of diseases, depression. The research team hypothesized that the majority of older persons affected by COVID-19 at the facility would have severe disease, and the mortality at the facility was expected high. The research anticipated significant associations between age, persistent symptoms, and severe disease. Participants were a convenient sample of residents at geriatric hospital. To be included, participants were required to be 65 years of age and older and a resident of the facility between the time period of March 2020 to March 2021. And once enrolled, participants' medical records were reviewed. A chart to patient records was done to complete these extraction forms for participants. Data extraction forms consisted of demographic information, COVID-19 test results, and patient-specific COVID-19 treatment findings and symptoms. Each data extraction is given a unique identification number. Consent to complete this research was obtained from the public hospitals of the ethics committee. Anonymity and confidentiality were ensured. Quantitative data collected was analyzed using the status 16 square and descriptive statistics, including central tendencies, measures, hold frequencies were applied. Hold counts for persons were calculated for items on our data extract form. So let's talk about what the geriatric hospital resident looks like when we broke down this study a little bit more. So we had 75 residents who were studied, and there were partially equally amounts of males and females due to the fact that we have 2 male, 2 female wards in the geriatric hospital. Most clients belong to the old subgroup, and 2 clients actually centenarians. They were 106 years old. Interestingly, the majority of patients were single and had no children. The majority of patients were residents of the facility for somewhere between 5 to 7 years. Most of the patients had at least one comorbidity, with the most prevalent being hypertension. 51 persons, or 76.1% of that population, was tested for the novel virus, and of those tested, 7.4% tested positive, 26.1% tested negative. And the main reason for testing was actually being symptomatic. You were also tested if you were exposed or needed readmission. Notably, mortality rate at the geriatric hospital was in fact high at 39%. And amongst the patients, the positive patients, 16.7% were asymptomatic, 28% had mild disease, 11% moderate disease, 25% had severe disease, and the others were critical. So, there's no significant association seen with treatments, and 9% of the COVID-19 positive died during this time period. But of those that survived, 14.3% had persistent symptoms that were documented, and persistent symptoms that we saw amongst residents were recurring cough, seizure disorder, and depression. And so, again, 40% mortality rate amongst our population. And it's notable that 79 patients in country who died, who were geriatrics and died during this study period, 30 of them were residents of our country's only geriatric hospital. And these high mortality rates at this one long-term care facility shows that long-term facilities are vulnerable to communicable disease. And these statistics highlight the need for evidence-based protocols to protect our long-term care facility. Now, within the study population, we said there were no statistically significant relationships between age subgroups of patients, as we expected, and severity of COVID disease. So belonging to the old subgroup was not a predictor of disease severity. And this unexpected result may have been due to other factors affecting the population, including the fact that they were tested early and there was early implementation of supportive therapy for them. The evaluation of COVID-19 on the hospital's population and the socio-demographic distribution and clinical features of the patients who we saw. And majority of those patients admitted to the hospital, we said, were single or they were without children. Now, this is interesting because a study done in 2015 by Banger found the same thing, which suggests that singleness and childlessness may actually be a risk factor for admission to a long-term care facility for our geriatric population. Again, no association seen between patient comorbidities and COVID-19 infection. The hospital multidisciplinary team, we aim to provide quality care. These participants in this study, they were monitored daily, registered nurses, they were assessed daily by a physician. Medication compliance was ensured. They were thoroughly discussed in interdisciplinary rounds. They received tertiary care, and so is our thought that this control of the patient's comorbidities may have resulted in less severe symptomatology and lower rates of morbidity as compared to some other facilities. The most common persistent symptoms seen in the literature was actually fatigue. This was not seen in our population. It's thought that because many of our patients are immobile or bedridden, it's difficult to assess easy fatigability or fatigability as a persistent symptom. The study is one of the first of its kind in the country. We were able to obtain socio-demographic and health statuses of geriatric patients, and the results do have implications for us in this population. The validity of the study is supported by studies from the National Institute of Aging and Danis et al., highlighting similar prevalence rates and mortality rates around the world. The retrospective study depended heavily on the availability and accuracy of medical records. Data was limited, challenges accessing files stored on other islands. Additionally, because the study was conducted at a single with only 4 wards, the study sample was limited, and this may have led to increased variability of our data. In the future, we hope we can focus on how the presence and availability of vaccinations can or has impacted outcomes. And we also would like to analyze how symptomatology and clinical findings has changed with our patients who actually showed persistent symptoms. Thanks so much. These are my references.
Thank you, Dr. Dossett. Do we have any questions for Dr. Dossett? Okie dokie. You guys found some questions. Dr. Dossett, you mentioned that, I think you said it was 30-something% of your patients who tested positive would have passed away after contracting COVID. What did you find? Because the understanding is when a patient dies and is replaced by another patient from the community. Did you get any analysis on the patient's positivity rate of those who are coming from the community?
So from what I gathered from your question, I hope I understand what you said. Our mortality rate during this period of 2020 to 2021 was 39%. Now, we do have rolling admissions often, but during this time period, we did not have rolling admissions. Protocols that we put in place to protect those patients who are currently residents to halt those admissions temporarily. So we did not have the challenge of dealing with the risk of potentially COVID positive patients coming in at that time. I think you were asking about admissions of COVID positive patients?
Correct, I did ask that question. So that then takes me back to one of the strengths that you mentioned of the study, which spoke to the correlation of communicable disease protocols in long-term care facilities. How do you correlate those two? If you did not take in anyone at all, is that the protocol that you advancing?
during that time, we did try to utilize any data we had available, or utilize as much data as we saw available in the research to put in place protocols that we thought could work for this facility. We were all so new to this disease or this viral infection, but we utilized standards of care that we used in other infections, tried to protect those those populations during that time. So yes, that would be the protocols that I was speaking about at that time. Yes, but we can't deny this high mortality rate nonetheless.
Okay, all right. Okay. So have you started taking on new patients yet?
We have, yes, sir, absolutely.
I would say that what I did find interesting were the information on I guess the analysis of the demographics of the patients that you have at the geriatric hospital. And as you mentioned later on in your presentation, it does have implications on how we use the hospital. Because right now it seems as if half of the patients are there for 7 or 13 years or more. And that's not necessarily what you'd expect to see in a hospital as opposed to a hospice. And maybe there's a need then for us to explore the ability to have an acute care facility for geriatric patients and a long-term facility for patients that are stable or need hospice care. But just I thought based on what you would have shown and also mention of how this would have provided a new insight into the spectrum or demographics of patients that are at the geriatric hospital.
Absolutely.
Okay. One more moment for any more questions to be asked. Thank you very much, Dr. Dorset. Okay, so our next presenter is Dr. Martin Frankston. Glasses, so I don't read them wrong. Ethical stakeholder involvement in a personalized manner rather than promoting wellness or in actualizing community-oriented medical education and research has been a persistent passion of Dr. Tony Frankston. Having begun his medical career in 1977, Dr. Frankston has practiced as a clinician, a public health professional, and more recently, academician. A graduate of both the University of the West Indies and Loma Linda University, Dr. Frankston has served as a hospital-based medical officer with Jamaica's Ministry of Health and Environment, as a medical officer of health with a USAID-funded community-oriented primary healthcare project in Trenchtown, Jamaica, as part of the Adventist Development and Relief Agency, as both a university-based and private evaluation researcher in California, assessing several federal grant-funded health-related projects, as the coordinator of the Youth Development and Teen Pregnancy Reduction Project of the Riverside, San Bernardino Counties Indian Health Service in California, and as Chief Medical Officer in the Turks and Caicos Islands. Dr. Frankston presently provides research support and guidance to students and residents at the University of the West Indies School of Clinical Medicine and Research here in Nassau, as well as for students matriculating at the UWI Mona campus. For the past 13 years, he has co-supervised the research of over 100 research projects executed with collaborating academic stakeholders and has relentlessly tackled related challenges, including improving peer-reviewed dissemination of findings. The topic for our last session, on which Dr. Frankston will provide a second keynote talk for this afternoon, is data to paper. Colleagues, please provide a listening ear to this presentation. Dr. Frankston.
Hello, everyone. Getting up this file here. Okay. Trust that everyone is hearing me.
Yes, we can hear you.
Wonderful. Hello, everyone, and it is an absolute pleasure to be here and to be again alive and well at another conference. Actually, paid my way to come to the first such conference put on by this university while I was working at Mona. Such was my interest in developing research capacity in the Caribbean region. I heard that this was happening through the UWI Mona, not UWI Mona, UWI School of Clinical Medicine and Research, Bahamas. I found my way here, and it has been an absolute delight. A year or two later, I was on faculty here, and we have been pushing out to, you said 100 and something, actually it's more like 250 to 300 pieces of research so far since the year 2009 when I joined. It's been very interesting, and again, I say it's a delight to be here. Data dissemination to health, to dissemination, and really we're looking here at it's towards health for all. And in the last slide, I will also include the fact that resiliency is important. It's important for the resiliency. I must quickly confess that a significant portion of my research, my presentation has been adapted from information that I got from the Centers for Disease Control on especially the latter half of this presentation. And I hope that, however, that for that reason, you may visit it and get the full presentation, but also that you'll be edified. Next slide, please. So my objectives are a little bit different from the ones that you might have seen in your program, but they're all in the same spirit to appreciate the nature of health data, describe data measurement, collection, and management, and to review briefly the whole business of data analysis, be it qualitative or quantitative, and then to move on to what will be the bigger portion of the presentation, which is the script describing the communication that is involved in data distribution, target audiences, challenge placements, etc. Next slide, please. So data is actually information, and it in science we call it data when we can measure it with reasonable reliability and validity. A little more on that later. And it comes to us sensorially, visual, auditory, gustatory, olfactory, tactile, etc. And as long as we have a device that can measure it, including our own brains, we will accept it in research, because when you can measure something, you can actually then do justice to the analysis and making sense of it in general, and using it for good decision making. Sometimes there is a qualitative capture of it. Back to that first slide, please. Yeah, right. Yeah. Sometimes there's a qualitative capture of it through sound recordings and pictures and thoughts, etc. And then sometimes, of course, it's a quantitative capture, various forms of energy that we use. If it's heat, we will use thermometers. If it is pressure, we will use manometers or other devices for pressures. And if it is distance, we'll use meters or inches, centimeters, nanometers, whatever. Whatever it is that we can do quantitatively, or even take qualitative data, measure it, then in complex array of variables, and then form a scale out of it. And then from that scale, we now have a quantitative measure, like we do, for example, the Beck depression scale and many other scales. And from a statistical point of view, what we have is categorical or qualitative data, which if you cannot rank it, we call it nominal. If you can rank it, like when you're giving, responses to attitudes towards things, we call that ordinal. And of course, if you can measure it in stable intervals, we call it interval data. And if on top of that, it has a true zero, for example, temperature would not be a ratio data, but it would be an interval quantitative data, but height and so on would be your weight, your BMI, those things would be ratio data, not ration. Forgive me for saying that, but for typing ration, it's ratio data. But they're all quantitative. And based on that, we can do wonderful statistics and make sense in a very quantitative thing where we can talk about the amount of things. And some people are very interested in knowing oftentimes the amounts of things using data that is available to them. Next slide, please. So we collect data, sometimes going for the full population. The population is known as the full selection from a set. And the population must be defined properly. And sometimes you'll have a population that you wished for, your results are going to go back to them. We call it the target population. And then a population that you have available to you, we call it the study population. But once you have that population and you've measured everybody, you have the full selection from which you get your data, and we have done a census. If you have to take a sample, and we hope that every sample you take will be a good example, but sometimes it's not, then that's from a sub-selection of the data, of the set of the information that's available to you for the study. You may use a probability-based approach, various kinds of random sampling that are beyond the scope of today's presentation. They range from simple random sampling through to probability, proportional to size sampling, to stratified sampling, cluster sampling, and even multi-stage sampling that we can go on as well. If you haven't done that and you've collected your data, then you have no basis on which to actually do statistics and trust them. I say that, and it usually shocks people because most people do studies on convenience sampling. And you should note that statistics that have been developed for our use have not been developed for convenience samples, but we still use them because we imagine that they might have been random. So we still use it, but I caution you to be very careful in applying the results from that data, because now you have done a non-probability based sampling approach, and therefore your results probably only describe that sample. And by chance, maybe it's close to reality, but you'll never know until you do repeated studies. And oftentimes, ethically, you cannot do random sampling. So sometimes what we do then is recommend that you do multiple studies on the same issue. And if in general, those studies are saying the same thing, then maybe you can be persuaded that your data is speaking to you to make decisions in a certain direction. Next slide, please. I talked about measurement being a key part, and the modes of measuring your data are sometimes quite subjective, where we use experts. We might drive through a community and do a windscreen evaluation, and then we go home and write a report on that. And you might speak to key respondents or have to ethnographers or etc. Or you might be taking a history and examination of a patient. To a large extent, it's subjective, but please do not discredit subjective work. The well-trained mind is an excellent source of reasonable data, even if you have to recall from people who have been doing something for years. You'll be surprised to see if when you bring the better study, how near you are to the expert's opinion versus the well-studied issue in most cases. And therefore, please have good respect for seeking advice of people from people who have been practicing in a certain area. I can remember years ago a study that was being done by Dr. Adderley, and she went to Dr. Sinkwi and she said, "What is the prevalence of anemia in pediatrics?" And when we completed this study was 0.5% away from what Dr. Zinkby had said, just from years of experience. So a word to the wise, don't discredit the power of the brain in a disciplined circumstance. Healthcare charts, documents, records, etc. And assessments of specimens, artifacts, etc. You've seen them in several of our presentations today. Rats right through. Survey questionnaires, they can be simple or they can be complex these days. And we have techniques for analyzing that as well. They're from technical devices that we use. All of these are modes of us getting our data. Next slide, please. Next slide, thank you. What is really important is that we have contextual considerations, and I'll show you in the next 2 slides what I'm talking about. Look at the truthfulness of what the data is after you, by the way we measure it and you handle it. And we call that the validity of the data. It's really looking at the accuracy of the data and truthfulness, in other words. And we could range from face validity right through to content validity and other various kinds, right down to criterion validity, where you learned about sensitivity and specificity and the various wonderful things, likelihoods that we can get when we play around with that. And that is one of the things that you have to pay attention to when we have captured data, we have measured data. The other thing you have to look at is how precise were you? In other words, how reliable? Was there good inter-rater reliability or an intra-rater reliability? Was there internal consistency? Did the group of questions that you have to measure that rheumatoid arthritis or that congestive cardiac failure or whatever, asthma or whatever, did those questions really work together and seem to consistently measure different aspects of the same things? And if you're getting a score when you do what we call Kronbach's alpha of 0.6, 0.7, 0.8, and so on, you know that it did it well. When we see 0.9 and 0.99, we say probably you even had some questions in there that you could have taken out because you are doing an overkill at measuring it. But look at those contextual considerations and these others that I will show you in this next slide. Next slide, please. Applied ethical issues. Whether you use an approach of a teleological approach where you're looking at the ends justifying the means, or whether you're using a deontological approach where you are saying there are certain things I must do as a duty. The core tenets that you must have when you handle data are the ones that we know so well. Respect for autonomy, that the off-person's auto means self, nomi is the Latin for governance. Respect for the ability of, especially when you're doing human participants, their ability to tell you the truth, to be faithful to your answering. You said, do not answer what you think the doctor wants or the researcher wants. Answer what really happens to you. Or also you, the researcher, being faithful and truthful to the persons as you consent them into the process, etc. As you give them privacy and assure them of confidentiality. And that things like you will remain anonymous in your questionnaire and when necessary, because some studies like before and after studies cannot be anonymous because you need to know the person so that you can do the follow-up survey, or else you will be mismatching the data and it will become useless or not trustworthy. Some of those things all feed back into respect for autonomy. And when somebody consents to give you a study, to do a study for you, what it implies is that you are now to do this study well, handle the data well, carry it through to proper capturing and keeping and etc. of the data, but also carrying it through to publishing and find some way to disseminate that data, which is the last point of today's presentation. Look at beneficence and non-maleficence. Primum non nocere, of course, means first do no harm. It's an idealistic model. Everything we do in research does a little harm. At the moment I ask somebody what is their age, it might offend somebody, or what, you know, and other questions. Just a simple thing like that. But usually those are called minimal risk issues, and therefore we say they are like the risk of life, crossing the road, sitting on a chair right now, etc. Nobody is going to compensate you for little mishaps. It was just by chance, and it is so rare that it will never happen probably. And but make sure that as you collect data, you collect it in that context. And justice, of course, is the other one. Whether we're using a principles-based or a casuistic approach, we must be fair and equitable. We must not select out to the, oh, let's use the folks at Fox Hill Prison because look at them, they're doing nothing all day. Let's go capture and study all kinds of issues on them, or the folks in homes of safety or children. Children are particularly ones that we have to get data from in a very respectful way. The side effect of that is that research in pediatrics suffers from not being as readily done as it is in research in adults, where you have a major consenting to share their data with you. And so that's a little side effect of having to make sure that we have justice in handling children as participants in our studies to get data from. The last of the contextual considerations that I would put to you today is study setting. Make sure that you consider the persons pertinent to this study as you look at this study setting. The context in which it is done, is it being done in a hospital? Is the data coming from a hospital? Is it coming from the emergency room? Is it coming from the community? Is it coming from a lab where everything is set up so that everything is controlled and people feel more relaxed that this was high standard data, etc.? What are the local and the immediate, as well as the national and the regional context in which the whole thing is coming at us? Next slide, please. One of the things that we have to do when we have data is we have to make sure that we get enough of it, whether we're doing quality size, if you're doing the full population. And there are formulas. Again, the scope of today's presentation is beyond that. That's a separate presentation because there are many ways, many formulas for calculating the appropriate sample size under different considerations of study design and objectives and so forth for this studies. But spend time to predetermine how much. Confidence is the complement of what we call type 1 error, which is lack of confidence, or the error of saying that something is going on when nothing is actually going on. Powers, on the other hand, is the error of the ability to say that something is going on when it truly is going on. There is a difference. There's an association. There's a change, for example, and so forth. Whereas the lack of power is the opposite of that. And be guided by the studies of design when you are doing all of that. Next slide, please. So as we move along, next slide. Okay, I see that we're back. I appreciate that. Could we move on to the next slide, please? I hope you got all of what is on this slide. And I know I already talked about that one, and now we're here. Make sure, for example, make sure that when you're handling data, that you check for data entries. The process that is a good, well-tried method is double enter your data as you're entering it into, let's say, a spreadsheet program or something. Meaning, enter the data from a questionnaire, for example, and enter it once more, or check it. And then before you move on to entering the next participant's data. Or I have a technique where people can quickly enter it for you if it's a lot of data, and then another group checks it for you and corrects any mistakes. Because you don't want any researcher information bias to be entering into your data. And then now you're ready for export, you export it, and make sure that there are backup copies, and don't keep too many copies of your electronic data. As I work with clients, I noticed that they have the first copy for every day that they met with me, and then they can't remember which copy is which one and so on. Please keep life simple. Just keep refreshing the original copy and maybe one other copy of the original as you update the copies, so that we keep life simple, and you're less likely to make information bias by just using the wrong copy with things that were originally erroneous, whereas the right copy would have had the corrected versions of whatever needed to be there. Export your data into a respected program, and there are qualitative analysis programs and quantitative analysis programs. The one we use the most in our setting is the IBM SPSS for quantitative work. And there's Nudist and NVivo and Ethnographer and all kinds of other ones for the qualitative research, or good old Microsoft Word and so on. Stay current and competent as you handle data. One of the things that you have to do when we handle data is to actually make sure that we do some training of ourselves in statistics and research and qualitative research if we are doing that. It is very unfair to you and to others to be researching a topic for which you have not schooled yourself in the fundamentals. And collaborate with local experts regularly. And it's never too early to come and collaborate with experts, because that saves us a lot of headaches as we move on. And move on now, please. Next slide. The analyses that we do are thematic analyses, for example, for qualitative work, and statistical analysis for quantitative work. And it's based upon probability and mathematics of a special nature that have given us wonderful models to use to make sense of what looks at first quite confusing, but by the time you have used the proper statistics, you pick out the kernels of information that make sense. The same for qualitative work as well. Let's go on to the next slide, where you would be doing coding of your information and focus group analyses, even making the folks in the focus group help you with the analyses of what they actually meant as you conduct the focus groups. You go for clarification and so on. And sometimes we can triangulate information from different sources. And there's a whole concept called grounded theory building. It's a wonderful way to do qualitative research. And then integrated approach where you could integrate quantitative and qualitative research as well. An example of that comes to mind is when Professor Christie and I and Dr. Rodriguez there in Spanish Town Hospital, we looked at why was it that women who knew their HIV status kept coming back pregnant. And so we didn't know how to build a quantitative questionnaire. But first of all, we did a series of focus groups. When we really understood that, we published that. And then we were able to do a 99 question quantitative survey. And we really got the amounts, the quantities, the percentages, and so on and so forth, that a lot of decision makers need to make sense of it. Next slide, please. And statistical analyses, a word must be said on that. Step one is really appreciating the fact that probability is a very useful thing that makes this possible. It helps us. The thing with probability is you know everything about the population, but you don't know what is the sample that you'll be looking at. Like, for example, you're playing a deck of cards. You know there are 52 cards in the deck, you know, the suites and so forth, but you don't know which hand the next person has. That's probability. And then you use that to make a decision, subjective in your case when you're playing the game of cards. But there are quantitative ways to do it too. Whereas with statistics, we take a sample and we know everything about the sample because we don't know much about the population. And then we backtrack, reverse engineer some of the tricks in probability to give us the answers to in what we call descriptive and inferential statistics. We can even use updating approaches where we know previous studies, what they've done, and we marry that information into what we do too, and the priori information, likelihoods, and so forth that we collect from a present study, and we update the information. And as I said, we can do descriptive statistics where we measure central tendencies as point estimates of information. And we always try to report those with accompanying measures of dispersion, you know, or spread. And of course, nothing is as wonderful as seasoning the final written report with tables and figures and so on. Even videos sometimes but that's more for when we're doing presentations. Then there's inferential statistics, where what you're doing now is not just talking about the sample that you did, as in descriptive statistics, but you're trying to infer what it would be like in the population from which you got the sample. And we can do interval estimations, whether we do confidence intervals or credibility intervals or tolerance intervals, or whether we do any of those other things like the full range of information. But there's also what we call hypothesis testing, and it could be bivariate or multivariate hypothesis testing. And usually what we are doing there is saying, what is the probability of a difference that we have seen being by chance or not, or an association that we've seen being by chance, no different from zero association, or whatever it is, a moderate or a strong association, or a change that we've seen. Was it statistically not different from a zero change, or was it a marked change? And so on. Well, hypothesis testing helps us to do that, going right back full circle to what probability can do to help us to see what is the p-value that goes along with that. And we usually set those critical p-values ahead of time, so that in the writing of the reports and getting the ethics approval, we play the game fairly. We don't go afterwards and try to change the critical p-value because we just want a new kind of statistical significance. Moving along, please. So now, the key here is that all of this leads us to making decisions. But before we go into the actual communicating of it, let us just see some of the quick decision aids that we can use in statistics. Next slide. All right. Okay, oh my goodness. Can you click on that again for me? Oh, yes, beautifully. That's it. Yes. So you see, it's coming in. Let's stop at that for the moment. If it's the predictor variable is binary 2 groups and the outcome variable is 2 groups, you know, we probably need to do a chi-square test. If you look in the middle down the bottom there, you see the categorical with categorical chi-square test or Fisher's exact. But if we go right back to the top, if it's binary, the predictor variables like males and females, you know, and the one is the outcome variable is continuous, then we might do the t-test, or if it's ranked, the Wilcoxon sign ranked, some ranked test. If it's before and after, we will do the Wilcoxon test, that is for before and after studies, the paired studies and so forth. And similarly, we have paired t-tests as well, and so on. If we have, like, what is your height and your weight, for example, or a certain blood chemistry result and another blood chemistry result, both of them are continuous quantitative things, we might want to do simple linear regression or just a correlation. And if we want to put in a variety of predictor variables, we might want to do a multiple linear regression. And but if it is binary data by binary, like, you know, were you exposed to something and are not exposed to it, and did you have an outcome or not have the outcome, then we might want to do odds ratios and relative risks, etc., based upon the study design. And if it is, we do logistic regression. And that's the cross-sectional and case control studies. Now, if you're doing a cohort study or clinical trial, the picture is even, the tests are even more savvy. You might do your risk ratios again, if it's binary with binary, but you might also now look at time to event and do a Kaplan-Meier or your log rank, using the log rank test for statistical significance. Or if you go to multivariate, you might use the Cox proportional hazards method and getting hazards ratios and so on. Keep on for me, please. But these are some of the things that are available to us. And yes, for repeated measure studies where you repeat the study over and over, which we do rarely, you can do more sophisticated kinds of studies. Next slide, please. Next slide, please. Good. Now we come to the final lap, and that is dissemination. Dissemination is the process of communicating information through various channels and media in order to reach various target audiences, national policymakers, health professionals, etc., right through to consumers. And oftentimes we forget that sometimes we really should be getting our results out in simplest forms to the persons who actually gave us the data in the first place by answering our surveys and so on. Next slide. And the purpose is to elicit immediate action, promote behavior change sometimes, to share new information or insights, solicit support or participation, educate about recent findings or accomplishments. And that's very much what we're doing here today as we go through the various presentations. And I hope you are enjoying the conference towards that end. And the magnitude of a health problem, that was something you saw right through the pandemic as you watched those epidemic curves being reported on, etc. And justify program activities is sometimes something that we have to use data for and to communicate the data, disseminate the findings from, so that we can actually get it to the people who will support a program once we have shown that it's a justifiable program, and to prepare for an upcoming intervention or program as well. Next slide, please. Next slide. Great. So one back for me. Okay, great. So establishing that communication message is one key component of doing this. And I'm sure as folks here looked at their presentations that they would want to present at this conference, they engaged in this very thing. They established the objectives and the purpose, etc. But conferences are not the only reason why we want to share data. Sometimes we want to share it in other settings as well, even involving behavior change and to support needs that we see, how the what, and how to do various things. And the next thing we might want to do is to define the audience when we are looking at how we want to define. Like everybody who presented today, your audience is a very academic audience. And sometimes your audience is your patient. Sometimes your audience is a community to which you're lecturing. Sometimes it is the media. Sometimes, in other words, it's professional, and sometimes your audience is non-technical, where you even involve politicians and so on and so forth. But the audience's demographics, priorities, beliefs, and fears, you should take time to appreciate those things so that you have a context in which you present that information. And that is important. Select the community channels or outlets to share the health message. The conferences on television, TV, magazines, billboards, flyers, even clothing. Sometimes data is shared on clothing that we have. Ask Dr. Jin, as she asked us to wear those HALT t-shirts. That's in an effective way, like a walking billboard on that is backed up by heavy data on the ways forward in reducing obesity in children. And ask any of you who have engaged in those things, whether it's breast cancer month, lupus month, whatever. But all of those things are ways of communicating your data, and when they should be done in a way that actually is true to what the data is saying. Read, understand, and comply with instructions to authors when you are sharing the data by published works through peer-reviewed work. For example, the West Indian Medical Journal, please, in Medical Journal instructions to authors, or the Lancet or whatever, before you go writing to them, and follow them quickly. Share that information with your collaborators, abide by them, and you are on the way to good data dissemination. Marketing the message is important, huh? And what we're talking about there is focus should be select relevant points and explain, because never do you have the chance to say everything that you want to say. So you need to say what are the key points that will capture the audience and therefore direct your message like that. Write directly and clearly a summary or an abstract. Too often we do not do that. For our research conference here, you might notice that you had to turn in an abstract. It is a good exercise. It helps you to say concisely the key points of what you are about to do. And, it helps us to get to the audiences that can, that we need to do, to pay attention to their cultural sensitivity issues as well as you do that. And the next slide, please. Evaluate the impact. Let's talk a little bit now about impact factors when we disseminate our information. And this particularly applies to presenting to journalists and so forth. Clarivate website has taken on the responsibility of calculating how many times people cite the articles from a particular journal, and using as something to divide by that, the denominator being how many articles were in that journal. And then they come out with what is called an impact factor. And I bemoan the fact that ours for West Indian Medical Journal has never exceeded 0.5 or but it has gone well in 2017 it went up to 0.46, and 2015 0.203. Back to 2022, it's so far as 0.171. What it means is that as we publish, very few people are referencing our articles in that particular source. But take on the other hand, the New England Journal of Medicine, they easily run in the 90s and the 100s. New England Journal of Medicine, their impact factor is 91.24. Their articles are heavily referenced. And what you're seeing here for 2022, a surge up to 176.1 is largely because of the COVID pandemic. People have been looking to those sources to reference, to write their own papers and make points for decisions and so forth, and write official reports. The Lancet has outdone them, and the Lancet is now in 2022 up to an impact factor of 202.7. And again, it's that COVID pandemic. Next slide, please. Well, folks, I want you to remember in closing today that good data measurement, collection, management, analysis, and dissemination are vital components of building the resilience that we desire. And I want to make a particular plea to us as you do research projects. Don't just do them so that your CV can look good and you can get into a graduate program and so on. Do them really for a more germane value, which is to get that information out, to collect it, to analyze it, and indeed manage it and disseminate it in ways that make sense. If you are publishing regularly the work that you do, you are doing a major step forward. There's still room for you to be more practical though. After you've published that work, also now try to get the media to report on findings of what we have been published, what we have been working on as it relates to breast cancer, as it relates COVID and so forth, but also as it relates to wellness. Let us remember to do that, and to also now use simpler means like town hall meetings, speech presentations at churches and other groups, and also to remember slide, and it is largely based from work I saw at CDC that I wanted to communicate to you, because we're in a situation searching hundreds of pieces of research now, and we are not disseminating them. We really do need to take that bull by the horn. We need to take that bull by the horn, and it is holding back many, many things in our countries, in our academic and our professional lives. But most important, it really is holding back our communities, our people that we serve, because they need to know what is the most that needs to be made for their well-being and the sustainability of that. thank you again for allowing me to present today. And I do wish the very best for this conference. For those of you who are interested, my mother got shipped to the Turks and Caicos Islands back from Cayman, and she's continuing her care in the hospital. And I'm with my family, taking good care of her, and she is responding steadily. So we pray, and I thank you for those of you who have been praying. God bless you, and go out there and disseminate that good data. Go get it in the first place. Thank you again.
Thank you, Dr. Frankson. Do we have any questions for Dr. Frankson? Okay. All right, thank you very much once again, Dr. Frankson.
I do have one. Sorry about
Right. Go ahead.
Dr. Frankson. Just wanted to see, you know, with all of this effort, how do you propose going to the next step with grant writing to be able to get funded research to come to the site?
That is, in the past, we have had grant writing workshops. There have been too few, I believe. Also, we need to increase our capacity as far as human resources is concerned to make sure that we have more people to help us with research. It is always refreshing to see that people can be delegated to act and so forth. When it comes to the matter of clinical tasks, but when it comes to research, if the researcher leaves, the researcher also has to either dump the project until they're back or do it on their leave. That's one way to improve things, is to increase our research human resource, because one horse can just do so much on a little tour around from the cruise ship around the Bahamas. Many horses takes many more cruise ship members, and they have a more wonderful time. A word to the wise on that. But the other thing is collaborating with people who actually know how to, and have had a track record of writing. And here at UWI, we are a part of MONA and so on, and we don't have to even be only a part of MONA. We are part of a whole university across the region, collaborating. Time and time again, I have encouraged that our Caribbean Institute of Health Research folks link up with us. The head of that is also the vice dean for research for the university. We could work with him to get workshops for us to do that, and to get not only workshops, but mentors for that. And also to help us to be on their grants as well, because this is a learned behavior. If you learn how a grant is managed properly, you are likely to be excited to write your own grant, because a lot of what it is about self-efficacy. And nothing like walking along with somebody who has been competent. That's how we train people clinically into the higher areas of clinical training. So this is how it should be. We need to get to that stage where we collaborate with those. Also to look at reaching out to other entities who can come and help us with that as well. There have been a few efforts to get our projects.
Sorry, Dr. Frankson, I know that you are aware that I'm very supportive of these collaborative research and international research and trying to get that moving along. And I think that that is definitely something I'd like to see from this site. And I think that there is significant amount of money to be made in research, and more importantly, the international exposure is something that cannot be paid by money alone. Thank you.
I must say this though that do not go first for international grants. Go first for your Ministry of Health and your national insurance and so forth allocating funds, because every country allocates and gives us a source. That's what National Institute of Health did for America. and they were kind to include it internationally, but we also have to obligations to fulfill to actually allocate funds for research. From the time I was chief medical officer in the Turks and Caicos, I knew that there was an arrangement through CARICOM that we should have 2.5% of the health budget of the Ministry of Health to be for research. And that has largely not been honored, and that needs to be revived and so on,
Right.
whether it's
So I
through
agree
the
with
Ministry
you.
of
I
Health or
think
through other
in speaking,
parallel avenues like national health and so forth.
sure.
Let me just finish, please. Whether it is those things, we actually have some of those. And also, you could have foundations formed that could actually be foundations for research, that you could also do that as well. And when we do that, we must consider data that we collect, managing it, putting it, and including disseminating it back to those entities that sponsor, so that they too can feel well edified that their investment is paying off.
No, I was just trying to say that in speaking with Dr. Roberts, this was one of the things that he had mentioned with the NHI, and I'm hopeful that we will see that come to fruition, where they will allocate a certain amount of funds for research. So I'm totally in agreement to looking and exploring that avenue as well. Thank you, Dr. Frankston.
You are most welcome.
Any other questions for Dr. Frankston or any addition to that conversation I was just having?
I need to just say, Dr. Swan, that I hope the point wasn't missed, that our disseminating of our data should not only be highlighted towards academic avenues. There needs to be disseminating of the data in the press and other friendly means as well, so that the persons that we collect the data from start to turn. We need to have our communities become more and more, as generations go on, partners with us in health, or else they will just become codependent and they will just look to us and say, well, you are the expert, whatever you say, instead of being an informed citizenry.
Thank you for that addition. I think, though, that just to add a little context to your last statement, I think when Dr. Sinky would have met with the minister during her orientation meetings, she mentioned the fact that UWI will be working towards strengthening its research agenda. There is also a national discussion on how do we ensure that the research that is done is fit to purpose and it meets answers questions that are being asked that we don't have answers for. So it's a wider conversation with not just someone doing a research and then sharing it with the public, but making sure that the research that happens is along a national agenda. It answers questions that the country needs answered. And therefore you can now find ways to get around it in terms of community awareness, campaigns, involvement in protocols, etc. So some of the things that you would have spoken to, but the part that comes before that is ensuring that there is an agreed agenda moving forward. So when the outcome comes, there are persons waiting to use this data, waiting to share the data, and waiting to create atmospheres and occasions so that the data is further disseminated.
Yes, and be careful of avoiding conflicts of interest too in the process. Like, for example, don't create like a joint ethics and research development committee. Make it an ethics committee by itself and a research development and so committee by itself, because you cannot have a committee that creates it in what is at one stage found to be even finding itself creating its own research and turning around to approve it. You know, that's conflict of interest as well.
To some extent, I mean, you call it conflict of interest, it's kind of cannibalism to some extent. But the other component of that we have to be wary of, and this is something that the Healthy Caribbean Coalition pointed out several years back, the parent company, our parent agency for HALT, is that we have to be careful as to how strict we are when we start talking about separation of individuals and critical purchases. we are only a certain size. So it will happen that you will have persons who are playing dual roles. But it does not necessarily mean that that is an ethical breach. You have rules and regulations that must be adhered to. And at some point in time,
Absolutely.
realize that rely on the soundness of the ethics of the individual that you're working with. Okay, so I think that was a good way to wrap up our session. I would say, Dr. Senku, that amongst your associate professors, there are a number of individuals who are interested in research, and touch me offline, I will tell you who they are. But I remember it was starting a discussion about the Office of Medical Staff Development. There are some very animated and energized individuals who wanted to see a research arm of UWI that was outside of the clinical education component. And so I think to Dr. Frankston's point, there's a need to bring in persons from the outside who may have experience. UWI, but UW, I mean, UWI is now form a relationship with the University of Hawaii. Just find partners who are willing to share their time and share their expertise and share their dollars to some extent with University of West Indies, SCMR. And the other part, the part of the spoke of Dr. Frankston about being cited in articles. That's an intentional thing. And so that's your other part of the planning. You're writing, for example, we had a presentation on COVID-19 and geriatrics. We had another one on acute injury in ICU patients. I'm sure at some point in time, someone's going to talk about COVID injury and acute kidney injury. And so just to reference those two documents now, even though they may not be published somewhere yet, but it begins to create that cycle of self-referral, that the system is building its own reliance on data so that it becomes within this region an authority on the data, on studies done on the human population, and by extension, to some extent, it now goes to Black populations. So there are ways that, again, it speaks to the wider strategy and how do we make sure that that strategy is well employed as we move forward with trying to translate not just the research agenda, but translate the research into clinical practice. All right, okay.
Thank you.
Are there any further questions that he would like to ask? I'll
just say one more thing, sir. Well, the person asked a question, and that is the data that comes from small areas of the country. I should have included under the ethics and statistics that there are ways to analyze that so that you don't, you can aggregate it with other adjacent islands and so on. So individuals' identity cannot be figured out, even though you might be anonymous. They know that that's the only person with that particular foot disease or whatever, So we also have to bear in mind as we handle data that we sometimes also aggregate it in ways that will protect people as well.
Yes, that's definitely one of the challenges that we have to be wary of. So if you want to look at this, a couple questions, several reminders from the presentations earlier today. If you have any questions to Dr. Indar, Dr. Claire, Clan, do you think just let Dr. Halliday know and he'll get the answers or the questions to them and then revert to you with the answers. In the chat group, there is a link for your CME feedback and claiming the 2 hours plus that we would have gone through the session. We're nearing on 3 hours now. And just, I would say that you take a photo of the link, or I think if you have registered, it would have been sent to your email as well. So take advantage of this, the year soon ends and you'll be scrapping to find those 20 CMEs, as you get your license for next year. And this is an excellent opportunity. Dr. Senku would have mentioned earlier as well that we have at least 6 CMEs available for this session, 2 today, 2 tomorrow, and I think 2 on Sunday. Not trying to get in the way of your regular routine, but trying to provide opportunities for you to gain and get an experience from the sessions benefit from these free sessions that have been provided. Yes, 10 minutes more and we'll finish. Less than 10 minutes, actually. So thank you once again. And as I would like to wrap up just by giving, it's basically expressing our thanks to Dr. Indar for bringing her remarks, Dr. Moxie for bringing remarks on the side on behalf of Dr. Darville, of course, Dr. Senkwi and Dr. Frankson, and taking us through, Dr. Senkwi, the 16 years of uninterrupted work of this day and this activity, and commenting on the role of you as an irreplaceable link for clinical practice and research to advance learning and create knowledge to foster innovation in the area of medicine in the country. And then Dr. Frankson on the techniques, steps to take when designing research activities to make sure those activities are valid and how to apply these findings to clinical application. I would like also to give our thanks and appreciation to Drs. Rakisha Claire Clan-Busink, Dr. Randa Darville, Dr. Diana Bannister, and Dr. Sasha Dorset on the resident papers. Special thanks in the background to Ms. Tanya Kelly, the Secretary Director, as well as Dr. Darren Halliday, who has provided his wonderful technical support and who serves as the committee chair. Thank you for each and every one of you for joining us and spending time this evening. And we hope that you join again tomorrow for the second session and enjoy the rest of your evening.
Thank you very much.